Hey everyone, my name is Ashley Babin. I'm the inpatient rehab speech therapist here at Baton Rouge Rehab Hospital. I've been at Baton Rouge Rehab for 5 years, but have been working with adult patients in the hospital setting for 9 years now. Today, I'm going to talk to you about dysphagia, what it is, how we assess it, how we modify diets to compensate for it, and what you need to be aware of if you are working with these patients with dysphagia. Okay, today we will cover dysphagia at a very general level, but after this course, you should be able to have a better understanding of what dysphagia is, including the different types of dysphagia, have an idea of how dysphagia is assessed, understand the different ways foods and liquids are modified for a patient who has dysphagia, and understand why every member of the treatment team, not just the speech therapist, needs to know this information. So what exactly is dysphagia? At a very basic level, dysphagia is defined as difficulty moving food from the mouth to the stomach. A recent expansion of that definition includes all of the behavioral, sensory, and preliminary motor acts in preparation for the swallow, including cognitive awareness of the upcoming eating situation, visual recognition of food, and all of the physiological responses to the smell and presence of food. So, swallowing is a much more complex process than maybe initially thought. So, why is dysphagia important to consider and treat? There are a lot of complications that can arise as a result of dysphagia. Those include malnutrition, dehydration, pneumonia, decreased quality of life, weight loss, aspiration, and choking. All of these deficits, single-handedly or combined, can compromise a patient's medical status and health, and could even cause death in serious cases. Before we begin delving into swallowing function, let's review a basic breakdown of the functional anatomy and physiology of swallowing. You can see this is a lateral view of the head and neck. Take notice of the different components and how we group them into the larynx and the pharynx collectively. There are 4 phases of the swallowing process. These include the oral preparatory phase, oral phase, pharyngeal phase, and esophageal phase. Oral preparatory phase involves the manipulation and mastication of food in the mouth. Oral phase involves the tongue propelling the chewed food, also known as the bolus, posteriorly until the pharyngeal response is triggered. Pharyngeal phase involves triggering the pharynx response and moving the bolus down the throat. Esophageal phase involves transporting the bolus through the esophagus and into the stomach. Speech therapists can diagnose and treat oral and pharyngeal causes of dysphagia. Sometimes esophageal issues are noted by the speech therapist during an assessment, but those issues would need to be diagnosed and managed by a GI doctor or other physician. Given the complex nature of the swallowing mechanism, you can see how various injuries, such as strokes, brain injuries, etc., can affect how well these muscles and processes work. The swallowing function is controlled by parts of the brain that regulate the motor movements of the swallowing process and also receive sensory information from these involved areas as well. The 12 cranial nerves send and receive sensory and motor information to and from all the muscles of the body. The information is processed in the brain. Trauma to the head, strokes, and other neurological insults can affect how these nerves function. Several cranial nerves are involved in the swallowing process, including cranial nerve 5, trigeminal, which is responsible for tactile facial sensation and movement of the chewing muscles. Cranial nerve 7, facial, which is responsible for taste and movement of the facial muscles. Cranial nerve 9, glossopharyngeal, is responsible for taste, the gag reflex, and elevation of the palate, along with movement of the pharynx and larynx. Cranial nerve 10, vagus, is responsible for taste, elevation of the palate, and movement of the pharynx and larynx. Even further, cranial nerve 11, accessory, is responsible for movement of the palate, pharynx, and larynx. Cranial nerve 12, hypoglossal, controls movement of the tongue. So that's a lot of cranial nerves. Even further, the medullary reticular formation, which is located in the brainstem, is a key component in controlling swallowing function. So much so, it's known as the swallowing center. This is why we tend to see a lot of swallowing dysfunction in brainstem stroke patients. Sensory input is key to initiating motor movements of swallowing muscles too, because the sensory receptors relay information to the cortex and the brainstem. So when we admit a patient with a brain injury, we automatically are concerned about and considering potential swallowing deficits due to the brain's complex and extensive involvement in the swallowing process. There are several non-instrumental and instrumental methods of assessing a patient's swallowing function. Speech therapy will likely begin with a bedside clinical assessment in which we assess overt signs or symptoms of dysphagia while the patient is eating or drinking different items. These signs may include pocketing of food in the cheeks, spillage of food out of the mouth, coughing, choking, throat clearing, changes to vocal quality such as a gurgly or wet sound, and a delay in the initiation of swallowing function. The therapist will then decide if a change in texture of the food and/or liquids will alleviate these signs and make appropriate diet change recommendations. If further testing is needed to fully assess the swallow, the speech therapist may complete a modified barium swallow study or a pharyngogram in which we assess the swallowing function in motion using X-ray imaging and barium contrast. These are helpful to find any invisible deficits of swallowing that may not appear during a bedside clinical assessment, and to help guide the speech therapist in creating a treatment plan to target the impaired areas of the swallowing. At Baton Rouge Rehab, pharyngograms are done in-house on the first floor by the speech therapist. So what does a speech therapist do if a patient has dysphagia? There are two approaches to treatment: compensation and remediation. Compensation involves changing the patient's diet consistency to work around the impaired swallowing function. It might also include certain head or neck postural changes to increase the patient's safety during oral intake. The other approach involves remediation of the swallowing function, which may involve electrical stimulation, sensory input, and motor exercises directed by the speech therapist to restore the swallowing function. At Baton Rouge Rehab, you will see patients on modified diets, especially on the brain injury unit. Let's begin with how liquids can be modified. Liquids can be modified by adding thickening products to them. We refer to 4 different liquid consistencies at Baton Rouge Rehab. Thin liquid is regular consistency liquid, like water. The textures then increase in thickness from nectar to honey to pudding thick. Use the gel-based thickening bottles located in the nutrition room, gym, dining room, or speech office to thicken liquids to the appropriate texture for patients with dysphagia warranting thickened liquids. The directions are printed on the side of the bottle. Foods can also be modified to make them easier to chew or swallow. We refer to 4 different textures here at Baton Rouge Rehab. Regular consistency is regular food. These patients can have food in its normal presentation and texture. The levels then become increasingly more restricted as we continue. Mechanical soft chopped requires foods to be cut into bite-sized pieces. Mechanical soft ground requires foods to be minced and moist, no larger than the size of a pencil eraser. Pureed foods must be smooth and lump-free. These require no chewing. If you're unsure of what is allowed or not allowed for a patient with dysphagia on a modified diet, ask the speech therapist or refer to our policy of modified diets. These policies can be located on forms online on the intranet and are also posted in the inpatient dining room behind the serving area. Here's an image of what some of those diet modifications may look like. The first plate A would be an example of a mechanical soft chopped diet. All of the pieces are cut into bite-sized pieces. Plate B would be a mechanical soft grounds plate. All of the items have been blended or run through a food processor to a minced texture. You'll also notice that the rice has been replaced with mashed potatoes compared to plate A. Plate C is the most restricted example we have here of a puree diet consistency. All of the items are smooth and essentially look the same besides the color. At Baton Rouge Rehab, there are several ways to tell if your patient has dysphagia or if they're on a modified diet. A patient with dysphagia should have a pink bracelet on their wrist with the diet written on it. For example, it may say MSC/Nectar Thick, which indicates the patient is on a mechanical soft chopped and Nectar Thick liquid diet. The patient's room door should have a pink sign that says aspiration precautions on it. This is a reminder to staff to check the patient's diet before bringing them anything to eat or drink and to ensure supervision at meal times. Also, inside the patient's room, there may be a pink sign posted by speech therapy that indicates the swallowing strategies the patient should follow in eating or drinking, such as not using a straw with liquids. The speech therapist will check appropriate strategies for the patient to follow with all intake by mouth, including how meds should be administered. If bringing the patient to a mealtime, the patient's meal ticket, which is the list of items on the tray, should be colored pink, and also the diet consistency listed at the bottom. So, what do you do if you encounter a patient with dysphagia? The biggest thing is to pay attention. If the patient asks for water in the gym, check their bracelet to make sure of any restrictions. If the patient is eating or drinking, are they following the precautions posted by speech therapy? Are they supervised? If the patient is coughing or choking, or their voice sounds gurgly, do a BAMS check. BAMS means check their bracelet. Are they on aspiration precautions? Check their meal ticket and ensure they're using any swallowing strategies that they should be using. Our patients with brain injuries are going to have a wide variety of neurological symptoms, in addition to potential swallowing deficits. They may be impulsive or unsafe, could have low levels of arousal and alertness, decreased cognition or motor control, or may simply be unable to tolerate the busyness of a mealtime in the dining room. These are a few practical steps everyone on the treatment team should follow to ensure that we are considering the unique presentation of these patients and minimizing the risk of aspiration as much as possible. First, always make sure your patient is awake and alert. In the beginning of this presentation, we discussed an extended version of the definition of dysphagia, which did include the cognitive awareness of the upcoming eating situation and visual recognition of food. If your patient is groggy or not awake or alert, don't feed them, even if it's time for them to eat. Set the tray aside and try at a better time when the patient is more awake and alert. We can help our patients with this arousal level by ensuring that they are seated upright as close to 90 degrees as possible with all meals and even during med pass if they are in the bed. Also, ensure that the patient is seated in an area with adequate lighting to assist with vision and arousal. If your patient is sitting in a busy area and showing signs of irritability, fatigue, or complaining of a headache, they may be overwhelmed by all of the excitement. Consider taking them to a quieter, non-distracting area to eat, turning off the television or otherwise reducing noise as much as possible. Make sure your patient's tray is set up in a way to allow them to visualize and access as much of their nutrition as possible. If the patient has motor deficits, open containers for the patient. If it's med pass time and the patient has a lot of medications to swallow, make sure they're only taking an appropriate amount at a time. This will be indicated on the pink swallowing strategy sheet in the room. The nurse has a copy of this in the MARS too when passing the meds. Every member of the team, including the clinical and non-clinical staff, patient, and their support system, plays a critical role in ensuring the safety of our patients with brain injury. Share the information you learned today with your colleagues, especially all the ways to identify if a patient has dysphagia. Remember the BAMS method, BAMS, check their bracelet, aspiration precautions, meal ticket, and swallowing strategies. If family is present, the information on the swallowing strategies sign will be helpful for them in case the patient requests something to eat or drink or it's time for a meal. Review these with the family and ensure that they understand not only what the restrictions are, but why they exist in the first place. If a family member doesn't know that eating a hamburger could put their loved one at risk for severe illness or even death, how can we blame them for doing something that they think will make the patient happier? Educate them on the basics of the diet and liquid texture recommended. If they want to provide outside food, be sure they know to check with the nurse before giving it to the patient. You can also demonstrate to them how to thicken liquids to the correct texture. The speech therapist can address any questions or concerns that arise regarding dysphagia patients. Our full-time team members are myself, Lori Wilson, Ann Burns, and Kim Diaz. Thank you so much for your time today. I hope you gained some useful knowledge today about dysphagia patients.
Baton Rouge Rehab Hospital is proud to be a leader in inpatient and outpatient rehabilitation services in Baton Rouge and surrounding areas. We pride ourselves on a commitment to restoring lives through compassion and a dedication to excellence. As the frontline staff members at Baton Rouge Rehab, we achieve these goals and standards through a responsibility to attain the highest level of competence and consideration for the unique and specific needs of our patients. Participating in hospital-wide education and seeking out opportunities to learn and grow as an individual is what can set you apart as a top talent contributor to the hospital. The education provided to you today highlights the 4 values of Baton Rouge Rehab: compassion, integrity, teamwork, and excellence. When you take the knowledge you have gained and apply it to person-centered, excellent care, you are contributing to the excellence of Baton Rouge Rehab. Thank you for your dedication.